Welcome to the Joy of Pathology. Thank you for joining us on this wonderful journey through the diseases that afflict us. I hope you learned something useful along the way. I'd like to introduce you to my assistant, Timothy.
Hello.
Timothy, are you okay?
Cat hair, cough. No, I'm not. You know I've been feeling a few things lately, like coughing all the time, usually until I cough something up that's really thick and gross. And I always feel out of breath, even doing the simplest tasks like bringing in the
Do you
groceries.
smoke much?
Yes, 2 packs a day, mate. Cough. You know I've been getting chest infections a lot more lately, and they take longer to go away. Could it possibly be due to me having a car sponge as lungs?
Possibly. I have a hunch, Timothy. I wonder if the audience does. The first symptoms tend to come on slowly, and they are often mistaken as signs of aging, lack of fitness, or asthma. I think you may have COPD, but let's do some tests. Let's do some spirometry. Should these symptoms appear, the diagnostic test used to confirm COPD includes the use of spirometer, where the volume of expired air from the patient is recorded over time. Let's get Timothy connected. In a patient with normal lung function, as you can see from the curve here, there will be a smooth rise and plateau. With increasing degrees of airway obstruction, it takes longer to blow out the air, so the upward slope of the spirogram will be much less steep. But how do we know it's actually COPD and not something else? Well, we can administer a bronchodilator and then take another spirogram to calculate new FEV1 and FVC values. These new values, FEV1, which is the amount of expired air in 1 second, the total amount of air in one breath, can be used to give a new ratio. If this ratio has changed to be more than 0.7, they may not have COPD. But if it's still less than 0.7, as was in the previous graph, then they do have COPD. And by taking the percentage of their predicted FEV1 to what it is now, we can check on this table of the severity. Given Timothy's symptoms and his presented spirogram, I would say he had severe COPD. If I was actually a doctor, that was. Let's visit someone who was diagnosed by a real doctor.
For this particular COPD that I have, I don't know if there's any other kinds, but mine was quite severe, and it was a management of exercise and basically a planned exercise program to try and introduce as much air into my lungs as each day as possible until I can build up to trying to lead a normal life in effect. Swimming become a big part. Swimming and exercise, aquatic exercises become a big part of my healing process. But as doctors inform me, I will never. I can improve what I am at now, but there is no cure for what has already happened.
Although debilitating and non-reversible, it is a preventable and treatable disease. Now, the Global Committee on COPD defines it as a preventable and treatable disease with some significant extrapulmonary effects that may contribute to the severity in the individual patient. Its pulmonary component is characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lung to noxious particles or gases. There have been documented cases as early as the 17th century referring to the same symptomatic disease as voluminous lungs or turgid lungs, a clue into how the sufferers of such a condition feel.
And that was actually like to build up the stages, because I was still working in the job I was working at, but as each day became more harder and more, I became more lethargic in my performing my duties, until finally the day come that I couldn't get out of bed, and I was virtually I had to go to hospital, and then I collapsed on the way to hospital.
Previously, the disease was majorly derived from external environmental factors like air pollution. However, with the popularity of smoking, it quickly became the leading cause of COPD. Therefore, the underlying afflictions can be caused by smoking, if you have in the past, presently, or exposed to passive smoking, environmental factors, like living in places where there is dust, gas, or fumes, or genetic factors. Some people have a rare form of emphysema caused by protein disorder called alpha-1 antitrypsin deficiency, or AATD, where the body cannot produce the alpha-1 protein to protect the lungs. Let's examine the main contributors. Emphysema, characterized by destruction of alveolar cell walls, resulting in enlarged alveolar spaces. The resulting large space traps air, since the air pressure gradient that forces oxygen into our lungs is broken, and therefore diffusion will not occur, as physical damage can be caused by oxidative stress produced by the high concentrations of free radicals in tobacco smoke. Similarly, chronic bronchitis, the inflammation response from white blood cells in the area, will also be a direct response to the inhaled irritants. We can also have chronic asthma, which will have eosinophil involvement similar to that of normal asthma, resulting in constriction of the airway. But this is chronic in nature. Worldwide, 175.5 million people are affected, or every 325 people. In Australia, over 1 in 7 people above the age of 40 have COPD, where it is the second leading cause of avoidable hospital admissions, as you can see here from the infographic provided by the Lung Foundation Australia. The gap clearly exists with this disease, with Aboriginal and Torres Strait Islander Australians having approximately 2.5 times the rate of COPD as other Australians. COPD is the 5th leading cause of death in Australia. Thank you for joining us on the Joy of Pathology.